Okay, so we're gonna have three guest speakers today. The first is Chris Chen. Many of you know him, fourth-year medical student, one of our star sub-Is, currently rotating with us. He's going to be presenting first, talking about differences in mortality, the effect of pre-hospital characteristics of traumatic brain injury, and that'll be followed with Dr. Gurvinder Kaur, who's our neuro-oncology fellow out of Northwestern, and she'll be talking about management of metastatic disease. So go ahead, Chris.
Okay, sure, thanks. So hi everyone, my name is Christopher Chin. I'm one of the sub-Is here at UM, and I'm just going to give a brief talk on pre-hospital factors that could affect or play a role in odds of mortality after traumatic brain injury. So a little background on TBI. So when we think about traumatic brain injury, what we're thinking about is basically any traumatic force or impact on the head that could lead to neurologic deficits or dysfunction in the future or in the acute setting. And when we think about who's affected, it was found in 2013 that in the US, about 2.5 million ED visits were due to TBI-related causes. And then of these visits, more than 280,000 of these individuals were hospitalized for TBI. And then of all people who died after injury in this year, it was found that almost a third of these injuries were caused by traumatic brain injury. And so these numbers are significant because, as you can see, they pose a significant economic burden on the United States. And specifically, in 2010, it was found that more than $75 billion was spent on TBI in the acute management and in chronic long-term care. And so you can see it's a significant financial stress on the U.S. as a single condition. And so when we think about odds of mortality after TBI, there are certain patient factors that have been found to be associated with doing better or doing worse after suffering a TBI. And specifically what has been looked at so far, what I'll be focusing on is patient characteristics. So in terms of patient race, it was found that minority patients, specifically Black and Asian patients nationally, have been found to have a higher odds of mortality after TBI when compared to white patients. And Hispanic patients also follow this trend towards significance, but not specifically statistically significant yet. In terms of insurance status, it has been found that in the insured group versus uninsured group, the uninsured group has a higher odds of mortality as well. And then within these insurance groups, specifically minority patients, follow this trend of having a higher odds of mortality within each insured versus uninsured group. And actually the effect is magnified in the uninsured group. So what this all means is that both race and insurance status are independently related to odds of mortality after TBI. But that can't be the whole picture. There has to be something else that could be related or possibly playing a role in how patients are doing after a traumatic brain injury. And so when we think about other things that could be affecting patient mortality after TBI, another thing you can look at is type of TBI and specifically the cause of TBI. So for types of TBI, what we think about two broad categories are non-penetrating and penetrating types of TBI. So for non-penetrating types of TBI, you're thinking about a TBI that doesn't involve any breach of the meninges, basically no exposure of the brain to a foreign object. Whereas a penetrating type of TBI is exactly the opposite, where you will find some kind of foreign object exposed in the brain or breach of the meninges. And prior studies have shown that for non-penetrating types of TBI compared to penetrating types of TBI, there was no associated poorer outcome when adjusting for age. But so for types of TBI, but for causes of TBI, some things you can think about are violent causes versus non-violent causes. So violent causes, you might be thinking of gunshot wounds, specifically to the head. And then for non-violent causes, you can be thinking of something like a motor vehicle accident or a fall or something. So here, this map is, what I want to talk about on this map is that, so it's a map of the United States showing specifically big metropolitan cities in the US, and each blue dot represents firearm homicides per 100,000 people per population density. And specifically what we see is that there's a significant amount of firearm homicides in big metropolitan cities. And if we think of a city like Miami where we live, there's a significant amount of Hispanic patients, Haitian patients, Black patients, so a significant amount of minority patients. So our question was, is there an association between violent types of TBI, odds of mortality, and minority patients? So for our study, what we did was we looked at patients who were admitted to Ryder Trauma Center from 2008 to 2013, who were admitted with an ICD-9 diagnosis, first or second diagnosis of traumatic brain injury. And we categorized our patients by different races. So we categorized them by white, Black, Hispanic, or other. And within each group, we found that there was no difference in GCS total score, but we did find differences in certain things. So specifically, we found differences in insurance status, pre-hospital transport, or how they got to the hospital, and the cause of injury. When we think about now odds of mortality, how these patients are doing after they suffer their TBI, what we found was a little interesting. We found that there was no difference in mortality by race, which was different from the national data that I was showing earlier, where they showed that specifically Black and Asian patients were doing particularly worse, specifically just by race. But in our study, we didn't find that specifically. Instead, what we did find was that cause of injury was associated with a higher odds of mortality rather than just race. Specifically, what we found was that weapon types or violent types of TBI were associated with higher odds of mortality than vehicular types or motor vehicle accidents that associated with traumatic brain injury. And so when we adjusted for sex, for race, and GCS total score, we found a few significant factors that were associated with higher odds of mortality after the TBI. And specifically, these were age greater than 50. We found insurance status when compared to Medicaid, specifically uninsured and Medicare. And then again, injury cause. So if it was a violent type of TBI versus a non-violent type of TBI, what we found was the violent types of TBI were associated with higher odds of mortality as well. And so here we have, I'm showing a graph with odds ratio on the y-axis. On the x-axis, we see within each race group, we're comparing by male and female. And overall, what we're looking at here is odds of experiencing a violent type of TBI. So as what we see here is each star represents a significant bar, and the blue graph is unadjusted, so unadjusted for anything. The orange graph is adjusted for age, and then the green graph is adjusted for age, GCS score, and insurance status. So what I'm showing here, and I'm highlighting these two graphs, is that in the white patient population, in males versus females, what we found was that males were at a 4 times likelihood of receiving a violent type of TBI compared to white females. In the Hispanic group, we found a similar correlation where there was a higher odds of receiving or suffering a violent type of TBI in the males versus female Hispanic group. However, what we found that was particularly interesting was that there was no significant difference in experiencing in likelihood of suffering a violent type of TBI in the Black male versus Black female group. And what this means is that Black females are at a higher likelihood compared to other females of other races. So specifically, they are almost at the same odds of Black females are almost at the same odds of receiving or suffering a violent type of TBI as Black males. And this finding was corroborated here when we see that when adjusting for age, GCS, and insurance payer, we found that Black females were a little more than 7 times as likely to experience a violent cause of TBI when compared to white females. So this is significant because it's different from what was found in nationally specifically. It seems that gender could be, quote unquote, for lack of a better term, protective against violent types of TBI in other races such as white or Hispanic patients, but not in the Black patient population. So before I conclude, just some limitations to acknowledge. We didn't really consider all the comorbidities of patients who were admitted to the hospital, and those comorbidities that could have affected mortality after TBI. These patients were admitted to a tertiary teaching hospital, so we do get some more severe cases. And additionally, the location of the hospital in Miami means that our patient population is very diverse, and we do have a lot of, like I said before, a lot of Hispanic patients, a lot of Black patients, Asian patients, and some patients from the Caribbean as well. So the patient population might not be as generalizable to the national patient population. And then again, one last thing to note was that we parsed out weapon violent types of TBI, but we didn't specifically look at each type of violent type of TBI. We categorized any violent type as one total category. So some conclusions from our study, what we found overall was that Black females in South Florida have a disproportionately increased odds of TBI and compared to females from other races. And actually, these Black females experience violent types of TBI on par with Black males at our hospital. So future work could possibly look at modes of transport to the hospital as possibly affecting why we found these differences. And we did find that there were differences in how how patients got to the hospital by race, so specifically like airlifted or by ground. And perhaps future work could look at, was it specifically maybe how the patient was doing in the field, or maybe travel time affected? And then future work after this could possibly look at analysis by zip code. Maybe it was distance from the hospital that could have affected why odds of mortality were different in these transport groups, or maybe it was something else. And then possibly allocate trauma resources based on these findings. So just some brief acknowledgements for everyone who helped out with this project. Emmanuel Perez, a resident at WashU, Dr. Ross Bullock, and Dr. Sham Gajavelli were definitely monumental in helping getting this all this research done. And thank you for your time. And if anybody has any questions.
All right, thanks, Chris. Gravinder, are you there?
Yes, I'm here. I can start my presentation.
All right, perfect.
Hi, everyone. My name is Gravinder. I'm currently a neurosurgery, neuro-oncology fellow with Dr. Komatar and Dr. Ivan. Today, I'll be presenting on evolution of management of CNS metastases, particularly in the era of targeted and immunotherapy. I'll do a brief historical review of CNS management, where has it been, and look at the current paradigm of metastatic disease. Additionally, review this recent scientific advances that have been made in the past decade and upcoming shift in the management of CNS disease with targeted therapy and immunotherapy. I'll spend a few minutes on my research that I did during my residency and provide some conclusions. As we all know, that brain mets are most common intracranial tumors in adults. They contribute to significant morbidity and mortality in these patients. About 10 to 30% of all cancer metastasize to brain. Lung cancers make up about 50% of all brain mets, followed by breast cancer, melanoma, and renal cell. Many patients who are diagnosed are actually diagnosed within their first year of their cancer diagnosis. Lung cancer patients within their first year of diagnosis, about 95% of them, in comparison to 50% of melanoma. And a lot of these patients, more than 50% of them, will pass away due to their intracranial progression. The median survival was 6 months, with range between 2 to 27 months, depending on number of mets and their overall extracranial disease progression. Thus, this is not surprising that patients with brain mets, their CNS site is the primary site of relapse in many of them. In lung cancer, about 61.4 patients have relapse in their brain mets, resulting in their demise. Briefly looking at the historical treatment of these brain mets, historically these mets were treated with systemic chemotherapy or whole brain radiation. It was in the early 90s when Patchell did a small randomized control study that demonstrated that surgical dissection of single mets with radiation not only improved progression and overall survival, but also provided patients with functional independence. Later in the late 90s, another randomized control study by Patchell demonstrated that whole brain radiation, in addition to surgery, in comparison to surgery alone, improved progression-free survival, but did not impact overall survival in these patients, thus making surgery and radiation a mainstay of treatment in single metastases. As stereotactic radiotherapy has come to the forefront, several studies have looked at the role of SRS in comparison to whole brain radiation to establish it as a mainstay of treatment. Andrew et al. In 2004 looked at a large randomized control trial where they looked at patients with single mets, whether they received whole brain radiation or whole brain radiation in combination with SRS. This was one of the studies that demonstrated that there was some propensity for improved survival in these patients who received combination therapy. However, Many other studies that followed have not been able to demonstrate this survival benefit. Study published in JAMA by Aoma et al. Looked at randomized control studies of patients with 1 to 4 brain mets who were treated with either radiotherapy alone or combination. They had about equal survival in both groups. Similarly, in Chang et al., they found that in this randomized control study that combination therapy actually resulted in cognitive decline by 4 months in comparison to radiotherapy alone. Similarly, Kosher et al. Looking at patients who received either radiation therapy or surgery or followed by radiation, again demonstrated there was no survival benefit, but these patients actually had worsening neurological cognitive outcomes. Though they did notice that the intracranial relapses were much less in patients who received whole brain radiation therapy. Brown et al. Again looked at another randomized studies, which again compared these two groups in 1 to 3 brain mets, and they found that there was no difference in survival. However, there was worsening in cognitive neurodeterioration. All these studies have led to American Society of Radiation Oncology now suggesting that whole brain radiation should not be added routinely to SRS for the treatment of limited number of brain mets. There are many other studies that have looked at the efficacy of SRS in treating patients, in post-surgical patients, and also in treating patients with multiple mets. Mahajan et al. In Lancet study looked at a randomized study, looked at patients whose 1 to 3 mets were surgically resected, followed by radiation or observation, particularly radiation here being SRS. And they found that the patient had improved progression-free survival at 1 year of 43% versus 72% in patients who were observed and did not get radiation. Another study published in Neurosurgery in 2014, it was a prospective cohort study, and it looked at survival in patients who were treated with radiotherapy for asymptomatic mets between range of 2 to 9 versus greater than 10. And they found that there was similar survival in both groups of patients. Limon et al. Further advanced that study and looked at what was the important predictor in these patients. It wasn't actually number of mets, it was actually volume or the size of lesions. And they found that around 10 cc was the demarcation where they noticed change in overall survival. There are limited studies looking at role of surgery in the treatment of multiple metastases, given that most of these patients were not included in many clinical trials, given their shorter life expectancy, and they were presumed to have limited benefit. There are 2 interesting studies that have looked at it. One is Peck et al. That was published in 2005. They found that the patients whose single metastasis versus 2 to 3 mets were resected in this 208 patients, they found that the patients had equal efficacy and there was no difference in survival. Shukru et al. Also looked at a smaller group of patients where they did multiple craniotomies in patients who had 2 to 4 craniotomies in patients who had larger mets in the range of 2 to 4 centimeters. And they, in order to provide symptomatic relief and allow radiotherapy to be more effective, they found the multiple surgeries to be efficacious and safe, and their median overall survival in their group was about 10.8 months. The conclusion from all this is that in patients who have good functional status and multiple lesions, resection of large dominant symptomatic metastases up to 2 to 3 may be beneficial, as long as they have their KPS score and their overall extracranial disease is well controlled. This is our, traditionally has been our paradigm for treating in the last few decades for treating brain mets, which involves obviously mainstay of treatment always is systemic treatment, and patients with brain mets will either get SRS in combination with surgery or SRS alone. In a smaller number of patients, whole brain radiation therapy has been utilized. Again, this is a little graph from Mayo Clinic study that was published in early 2000s, which basically is making a point that when deciding which patients to treat in terms of surgery versus SRS, versus whole brain, their overall disease status extracranially as well as intracranially makes an important factor. The number of lesions that can be treated, obviously in the last decade has shifted, as studies have shown that treating multiple lesions in asymptomatic patients actually showed survival benefit. So even though we have this current paradigm that we've been using, there have been significant failure associated with it. And there are a number of reasons why. First is that there's inadequate systemic therapeutic penetration of blood-brain barrier. In the past, there have been limited treatment options for patients with brain mets, and a lot of these clinical trials that looked at different chemotherapy agents did not include brain mets patients. So their penetrations from these studies and their benefit was limited, at least did not establish that. And also, therapies were limited by poor understanding of metastasis, growth, and survival in brain microenvironment. Additionally, new studies and data have suggested that there are potentially oncogene alterations in brain mets in comparison to their primary tumors, creating a divergence of therapeutic response. Particularly this one study that was published in Cancer Discovery in 2015 by the MGH group looked at primary lung, breast, and renal cell cancers in 85 patients, and they found that these patients with brain mets had potentially altered clinical targeted mutations that were not found in primary tumor. They also had many oncogene alterations that were separate and different from their primary tumors. And these brain mets behave genetically very different from their regional lymph node and extracranial metastases. They found that about 53% of these patients had key mutations that were primarily different from their primary tumors. Thus, it's difficult to base patients' treatment of CNS mets just based on their primary tumors. Additionally, in the last decade, we have a better understanding of the molecular drivers of brain mets and additional understanding of how CNS penetration of drugs across blood-brain barrier can be improved and how it is affected. Here's a list of recent review that basically looked at over 15 different markers that have been established in brain tumor mets. Additionally, we have a development of novel and effective treatments in targeted therapies and immunotherapies that are providing better systemic control than the traditional chemotherapy regimens that were present in past. Particularly tyrosine kinase inhibitors, which are, these are the proteins that are expressed by cells. They are cell receptors that play a key role in cell proliferation, differentiation, survival, and adhesion. Thus are important targets in brain mets and in general in cancers. There are over 30 different tyrosine kinase inhibitors that are approved by FDA currently, and many are under clinical trials and in development to treat these cancers. Some of the common tyrosine kinase inhibitors are EGFR, HER2, VEGF, that are often part of our treatment regimen. Additionally, there are many new studies that have come up or are ongoing that are looking at not just tyrosine kinase inhibitors, but additional immunotherapy, particularly PD-1, PD-L1, and CTLA-4 targeted therapy that help with limiting the immunosuppression and letting the cytotoxic T cell basically attack the cancer cells to limit its progression. So briefly, a quick review of some of the landmark studies. The first study is looking in lung cancers, lung cancer with ALK mutations or ALK positive patients. It looked at crizotinib, which is a first-generation tyrosine kinase inhibitor of ALK. It basically showed that there was improved progression-free survival comparison to traditional chemotherapy, though overall survival was very similar. Progression-free survival was about 10.9 months in comparison to 7 months with traditional chemotherapy. And 1-year survival with the inhibitors was about 84% versus 79% in traditional chemotherapy. However, there has been advancement even within the tyrosine kinase inhibitors. This is a study looking at a second-generation tyrosine kinase inhibitor, alectinib, which actually has a significant improvement in its blood-brain barrier crossage because the earlier first generation had a limited penetration. This study showed that the patient actually had further improvement in their overall in their progression-free survival. And in addition to that, in CNS Mets, it showed significant disease control. At 12 months, it was found that 9.4% of the patient progressed in comparison to 41% of the brain Mets patients who progressed with the earlier first generation agent. Similarly, in the EGFR inhibitors for lung cancers, this is a second generation inhibitor looking at the phase 2 study, which basically found that patients had improved progression-free survival of 18 months in comparison to the standard EGFR inhibitors that have been used earlier. Their duration of their response was also longer, about 17 months in comparison to 8.5 months. These effects were, improvements were seen both in patients who did not have CNS Mets and patients who have CNS Mets. So this was an important discovery and has become standard of therapy. Additionally, in patients with melanoma, treatment with dual agents, particularly inhibitors of BRAF, have shown that there's an increased intracranial response of about 58% of patients who were never treated before, who are radiotherapy naive, had a significant improvement and response to these two agents in combination. Furthermore, studies looking at the immunotherapy have found that with PD-1 block in combination with CTLA-4 inhibitor, patients with untreated asymptomatic melanoma patients were found to have improved response. Here in this study, they had looked at 3 different cohorts of patients. Either they were treated with combination therapy or just PD-1 inhibitor alone, and they found that there was a response in CNS Mets in both group of patients. And of course, combination therapy, there was about 40% of the patients who showed response versus 20% in single arm. Furthermore, additional studies have shown that about 52% of the patients with previously untreated melanoma Mets obtained an objective intracranial response following the therapy, which was very similar to their extracranial response, which was about 47 months. At 6 months, the rate of intracranial progression free survival was around 64%, which was similar to the extracranial, was around 70%. Overall survival in this study was about 81.5% at 12 months, and median survival had not been reached. Similarly, a study looking at Pembro, which is a PD-1 inhibitor in melanoma and lung cancer patients, found a significant response in the treatment of their CNS Mets. They found that about 33% of the lung Mets showed response to the treatment, and 22% of melanoma patients had good response. There are a few studies that have tried to look at the role of combining these either immune therapies or targeted tyrosine kinase inhibitors with stereotactic radiosurgery. This is a meta-analysis for melanoma brain Mets, looking at combination of SRS with CTLA-4 inhibitor, which basically showed in these studies that there was an increased survival compared to radiotherapy alone. Conclusions from these studies is that the patients with and without CNS Mets have shown significant improvement in their progression-free survival, and in some studies in their overall survival to both tyrosine kinase inhibitors and immunotherapy. These results are certainly shifting the paradigm for systemic therapies for these patients, rather than being a salvage therapy, making it an upfront treatment for these patients. Obviously, there are very limited studies of combining these agents with radiation therapy in terms of timing. So we need further reevaluation of the role of radiation therapy in further studies. Now, just briefly, during my 6th year, I spent time in Dr. Block's lab, and one of the projects that we worked on was looking at immunosuppression in brain Mets patients. So we collected blood from asymptomatic early stage lung cancer patients, as well as brain Mets patients, and also their cohort matched healthy patients. what we found was that in their peripheral compartment, these patients who had brain mets had significant immunosuppression. They had higher number of PD-L1 expressing monocytes. They had higher number of Treg cells as well. And their PD-L1 expression was independently associated with worse outcomes in patients. Additionally, we looked at the response of immunomodulation on stereotactic radiosurgery. And in our cohort of 125 patients from Northwestern, we found that patients who had immunosuppression defined by their lymphopenia as ALC less than 1.0, these patients had worse overall survival as well as progression-free survival. So their median progression-free survival was about 86 days if they were lymphopenic, compared to 255 days in patients who were non-lymphopenic. And their median overall survival was about 89 days compared to 581 days. Thus, these studies demonstrated that that immune targets and timing of the treatment can be of great importance in patients with brain mets, especially when these patients are, along with the targeted therapies, are getting chemotherapy, resulting in change in their peripheral compartment. Maybe it's important to boost their immune system before giving them SRS. In terms of future directions, where do we go from here? I think this is an exciting time in the treatment of brain mets, given that we have a lot more therapies that are available, and a lot of them are looking particularly at brain mets. And in the recent development of many better understanding of many molecular markers, metabolic environment, and that has shaped the brain mets development, we feel that this will further advance the treatment. I think understanding that looking at the primary tumor may not help us treat the brain mets with target therapy that well, given that brain mets have very different mutations. As we found in that study, over 50% of the patients had very different mutations than their primary tumors. And also in terms of research, there are very few established experimental models, animal models particularly. In case of GBM, we have at least dozens, if not more, animal models that we can study and experiment different drugs on, but there's no standardized models that are available in treatment of brain mets. Furthermore, we need to better understand the immune system interactions and how we can make systems that can help pass the blood-brain barrier in a much better way so our patients can get better treatments. That's all for today. If you have any questions, I'm happy to take any questions.
Killing some time, maybe we could go over one of the board's questions from last night. And just kind of give a little bit of feedback since it's fresh in all the residents' minds. And so I just want to take you through maybe one of the cases that I presented. So, I think that when the residents do the oral boards, you kind of have to think of everything kind of in a very structured way. So you need to have kind of your preoperative way of thinking about cases, your kind of your H&P, and then your preoperative like blurb about what you do preoperatively, and then intraoperatively what you do, postoperatively what you do, and then complications what you do. In each one of those sections, you should in your mind have like a protocol. And Bobby Stark does a great PowerPoint, which he's going to give, I think, in a couple weeks to kind of bolster this idea. But, so when you have a case like this that's presented, you say, okay, 50-year-old female who presents with worsening vision, headaches. So I would do my typical, preoperative assessment with a full H&P, physical review systems, any kind of pertinent medical history that would be relevant in this case. I would ask the patient, and then I would eventually get any pertinent labs, and then you get imaging. And that way you kind of cover a 5-minute H&P and whatnot within like 1 or 2 sentences. And that way the reviewer has to be like, okay, well, there's no pertinent medical history for this case. There's no pertinent labs for this. And, and then they could say, okay, but here's the imaging. But if the worst they could do is say, well, what do you consider pertinent labs to be? And then you say, oh, okay, well, labs must be important in this case. So then I would say, well, then I would do my CBC, Chem 10, you know, whatever you would think for that case. So then if you get to imaging, you know, always when you see the imaging for your case, you want to describe what you're looking at first. Don't just say, this is a meningioma. So you try to like buy time to make sure that your mind is processing. So you'd be on the top row, we have a coronal, sagittal, axial MRI with and without contrast, describing a homogeneously enhancing lesion that's well circumscribed and appears to be arising from the right clinoid with significant mass effect. And then you can see in the bottom rows, we have a T2 axial scan, not a lot of edema surrounding the mass, indicating that this is probably a slow growing lesion, supporting the fact that is a meningioma. We can see here that there is some iso-intense lesion going into the optic canal on the bottom left scan, and you can see the clinoid there pooching into the tumor. So, and then you can have your CT scan, you describe that. So then when you get to the OR, you know, you always kind of say, okay, I have my normal protocol for going to the OR. So I'm going to take this patient to the OR for a right-sided orbital pterional with a clinoidectomy and extradural approach. My typical pre-op protocol is, you know, the patient is consented, all the pre-op labs are confirmed, EKG medical clearance has been achieved. The patient goes to the OR. We give them our standard preoperative medications, which includes, you know, Keppra, Decadron, mannitol, and antibiotics. A timeout was performed. Blood is prepared, and then we proceed with the case. And again, you just ramble that off in 1 or 2 minutes, and it covers all of the questions that the reviewer would have in your board. So, you know, for this case, there was an intraoperative seizure. And so, you know, if you didn't say that I was going to give the patient Keppra, then that's a red flag for your on the oral boards itself. And so if you just kind of get used to, you know, spine protocol, cranial protocol, these are kind of the things that I would cover, then in one sentence, and you just practice that sentence, this is my usual preoperative protocol, then you'll just get used to saying it for every single case. And by the time you get to your third case, whenever they're like, we know what your preoperative protocol is, you don't have to say it again. And then, you know, intraoperative and postoperative complications. I mean, if you read Dr. Levy's book, he really describes them well. And I would say that that's probably the most important part of the book to read on any of the oral review books. And it's literally just one chapter, and it's about 20 pages. And so, you know, you guys should all read that next year before we go through this mock oral boards, because it gives you basically exactly the protocol for every complication that you could see in neurosurgery that's going to be on the boards, which are going to be things like, you know, intraop seizure, intraop venous embolism, intraop bleeding and herniation, loss of motors for a spine patient, you know, postoperative seizure, postoperative wound infection, postoperative hematoma, take back to the OR. I mean, that's pretty much almost all of them that they're going to test you on. And so for each one of them, you should got to just know exactly what are the steps to deal with that. So in this case, intraoperative seizure. So, okay, well, I would do my intraoperative seizure protocol, which is, you know, first I would ask them to give a dose of propofol in the OR. I'd raise the head of bed. I'd give choline. I'd put pressure on the brain. If it doesn't stop, then I would consider giving some kind of paralytic to the patient, and then reassess the patient at that time point. If the brain is still full, you know, my options are to get CSF, give additional mannitol, raise the head of the bed, lower the PCO2, place an intraoperative EVD. So you should just have those 5 things kind of ready to spew out immediately. And that way, even if your reviewer, so in many cases, you guys would say, okay, well, I gave propofol. And then I said, okay, well, the seizures are keep going. Well, then I give choline. So if you just give the whole protocol up front, then they won't kind of keep leading you down this track of worse things happening. As you could say, these are all the things I would do for a seizure until completion. And then they kind of will force you to move on to the next step and kind of get you through the case faster, rather than saying, okay, well, now the brain is really herniating out and the body is shaking off the bed. And then it raises your heart rate and gets you more stressed out. And then it kind of throws you off your game. So that was the case in here, seizure, and then the brain was swollen. Many of you got got through that really well, really nice job. Many of you were able to place an EVD for brain swelling and continue with the case. And then post-operatively was the same thing. Patient then comes back on post-op day 2 in the ED unresponsive, right? Already had an intraoperative seizure. I think most of you picked up on the fact that the patient had an intraoperative seizure. So most likely when the patient comes back to the ED, they're going to have a seizure. And then, you know, managing post-operative seizure, you know, a couple of you consulted neurology, which is great, but on the boards, you're not allowed to consult anybody. So you need to know how to manage status epilepticus post-op in the operating room. And again, you should just have your protocol. My protocol for managing this is to give 2 of Ativan and then give another 2 of Ativan and another 2. And if that doesn't break the seizure, then I'm concerned that the patient's in status. You know, I secure the airway with intubation. We decided to give propofol. I already have given 1,000 of Keppra on admission. If that's not working, then I would consider a second agent. And then you have to know the doses. If you're going to give phenytoin, if you're going to give Dilantin, if you're going to give something else, you got to know exactly the dose and what you're going to give. And then, you know, and then you say, and in the meantime, I'm ruling out any other etiologies. We get a full set of labs. We get a CT scan. The EEG is hooked up. If that still doesn't break, then I escalate to the next level, which would be, you know, after propofol would be paralytics with pentabarb coma. And you kind of just tell them your whole protocol up front rather than saying giving one thing at a time. Well, I give 2 Ativan and then wait for the reviewer to respond to you. You kind of recognize, okay, you're talking about postoperative seizure complication. I know this really well. Here's my entire protocol at once and get me through this complication and get me to the next case because I know this. Rather than trying to wait for this feedback of, let me do this, let's see what happens. Let me do this, let me see what happens. It just will help speed up the whole thing. So, and I think you could apply that strategy to whether it's a spine case or a, you know, a cranial case or a trauma case. Each one of them are going to kind of have that same flow as you go through it. So that was just my 2 cents. I think everybody did a really, really good job yesterday. I was only there for half of it and the week before too, but I was very impressed. But I think that the workflow, the idea of doing the mock oral boards is to prepare you guys for the real oral boards when you graduate. And so the more we could kind of get it exactly like that, I think the better it'll be for you guys.
Dr. Ivan, we have Dr. Lang.
Perfect.
Hey, Mike, that was great. Thank you so much for kind of filling in. That's some great information. Fred, so I'm going to introduce you. Are you all set to go?
I was just chatting with them. I think he's having some trouble with the microphone.
Okay. Well, I'll do the introduction.
Thank you.
While he sets up, I think everyone knows who Dr. Fred Lang is, but for those of you who may not know, he is the chair of neurosurgery and director of the Brain Tumor Center at MD Anderson. He's also the Bo Biden Chair for Brain Cancer Research. Dr. Lang went to med school at Yale, followed by residency at NYU. He then did a surgical neuro-oncology fellowship at MD Anderson, where he stayed on as faculty in 1996. He's a world-renowned surgeon and researcher. Clinically, he's best known for being an expert in insular gliomas. And research-wise, he's known for his novel clinical trial development. He's the PI of the MD Anderson SPORE grant and also has multiple NIH grants for his work on gene, viral, and cellular brain tumor therapies. He's won pretty much every brain tumor award available to neurosurgeons, including the Guha Neuro-Oncology Award and the Bittner Tumor Section Award. He's the past president of the Society of Neuro-Oncology. He's the past chair of the tumor section, and he's got over 200 publications with 24 book chapters. So clearly, Fred Lang is one of the biggest names and one of the most respected tumor surgeons in the world. We are delighted to have him join us today as our endowed visiting professor. So Fred, please take it away.
Yeah, can you hear me?
Yep, absolutely.
I'm having a little trouble sharing my screen, so hang on 1 second. Something happened here. Share screen. There we go. Can you guys see my screen now?
Not yet, doctor. Redo it again. Go back. There you go. Now we can see it.
You can see it now?
Yes, perfect.
And is that that's the correct view, right? You don't see this?
Yes, it's perfect. You're ready to go, doctor.
Great. Well, good morning, everyone. It's really a great pleasure to be here this morning and to speak with you all. As the Andrew Connor Curtis Endowed Speaker, I know you've had a lot of outstanding lecturers in the past over the last several years, and it's really an honor to be selected to give this talk. And I hope I live up to the standards of the prior speakers. So what I thought I would do in the next couple of half hour, 45 minutes, is describe to you some of the work we've been doing on what we like to call biological therapies. Let's see if I can get this to advance. So here are my disclosures. I am a patent holder for one of the agents I'm going to talk about, but I don't have any financial affiliation with the company that licensed this agent. Yeah, so what I'm going to talk to you about is a group of therapies that we like to call biological therapies. And these are natural, often living agents whose intrinsic properties can be exploited for cancer therapy. They include things like oncolytic viruses, stem cells, microRNA, and exosomes. So what I'm going to talk to you about this morning is several of these. And we become interested in these agents because in these biological living agents, we think that you frequently find that nature has provided hard to replicate solutions to many of the problems of cancer therapy, such as targeting the tumor cells, overcoming resistance, attacking heterogeneity, activating the immune system, as you'll see, and even crossing the blood-brain barrier. So what I'm going to talk to you about this morning is two of the biological therapies that we've been working on over the last several years, including an oncolytic virus called Delta 24 that we developed at MD Anderson. And my focus here is to show how we changed our understanding of the mechanism of this virus from being a direct oncolytic agent to actually being a form of immunotherapy. And then I'll tell you about another biological therapy, and that's the use of adult stem cells, particularly bone marrow mesenchymal stem cells, to help us to deliver this oncolytic virus, Delta 24. So I know you're all familiar with glioblastoma. It has several features that make it particularly difficult to treat. The first is that, as you know, it's a very diffuse tumor. So that means that in addition to the contrast-enhancing solid portion of the tumor, there's also these infiltrating tumor cells, often seen on the flare or the hyperintensity on T2. And these cells actually infiltrate or diffuse widely throughout the brain, often to the other side of the brain. So any therapy that we have for glioblastoma has to not only be able to treat the local solid mass, but actually be able to spread widely throughout the tumor. The second feature is that this is a highly infiltrated tumor. And by that, I mean that the tumor cells are juxtaposed to normal cells within the normal parenchyma. So that means that any effective therapy has to be able to kill the tumor cell and spare the normal neurons and the normal astrocytes within the brain. Third feature is that it's highly resistant. It's probably one of the most resistant tumors, and almost every agent that we've tried is resistant, or the glioblastoma is resistant to these agents. And fourth, it's one of the most immunosuppressed tumors of all cancers. And so it was to really address the first three issues that we developed Delta 24. And as we worked on Delta 24, we learned that it actually also addressed this fourth issue of glioblastoma. So what is Delta 24? Well, Delta 24 RGD is a replication competent tumor selective oncolytic adenovirus with enhanced infectivity. It was actually developed by my colleague and good friend Juan Foyo. And this is a good example of an interaction between basic science and translational clinical physician as a way to advance treatments. And we've been working together now for over 20 years. This agent was in fact licensed to a company called DNatrix. So Delta 24 has certain features. The first is that it is a replication competent virus. It's an adenovirus, which is a common cold virus, so it's a relatively low pathogen. But most importantly, because it's a live active virus, that means if you inject it into a tumor, this virus can get into the tumor cells. It then replicates inside those tumor cells. So if one viral particle gets into the tumor cell, it will make about 1,000 or 10,000 copies of that viral particle. That virus is then results in the lysis or the destruction of the tumor cell. with subsequent release of all the viral particles, which can then go on and infect more tumor cells. So in this process of infection, replication, oncolysis, release, and reinfection, this virus can then theoretically spread throughout a very diffuse tumor, addressing the first feature of glioblastoma. The second is that this virus is tumor selective. The basis of that tumor selectivity is this 24 base pair deletion in the so-called E1A region of the gene, of the virus, the E1A gene. And that's how we gave it its name, Delta 24, for deleted 24. And the effect of this is that this deletion makes the virus only replicate in tumor cells and not normal cells. So simply, E1A is the first gene that's made when a virus enters its cell. The job of the E1A protein is to bind to retinoblastoma. And as you know, retinoblastoma is the guardian of the cell cycle. By inactivating retinoblastoma, you free up E2F. That drives the cell into the cell cycle, and then the virus can use the cellular machinery to replicate itself. Well, because Delta 24 has a mutation in E1A, when Delta 24 enters a normal cell, it's unable to bind to RB, and therefore it can't replicate in a normal cell. However, in a tumor cell, the retinoblastoma protein is almost always mutated or inactivated. In fact, in glioblastoma, almost 100% of the cells have either a mutation or an upstream inactivation, resulting in the cell always proliferating. And as a result, the virus, the E1A, doesn't have to inactivate retinoblastoma, and so this virus replicates very easily in the tumor environment. The last feature is that we've enhanced its infectivity. Specifically, we've inserted an RGD motif. This is an integrin binding motif into the fiber knob of the virus. This allows the virus to enter cells independent of the so-called Coxsackie adenoreceptor, which is the normal receptor, and it can enter cells strictly on the basis of integrins. Since integrins are higher on tumor cells than normal cells, not only does this increase infectivity, but it also enhances the selectivity. So now we've tested this virus in a large number of preclinical models. We show that it's highly effective against the professional glioma cell line U87, curing almost 60% of mice with those tumors. We've also shown that it's highly effective against our patient-derived glioma stem cell lines. As you know, these grow as very diffuse tumors in the brains of mice. And we have about 40 of these that we can implant in animals, and we have not yet found one of these glioma stem cell lines that the virus is not able to kill. So it's this then addresses the resistance feature in which this virus is able to attack many of these glioma stem cells and overcome the heterogeneity. In our preclinical studies, we also wanted to prove that the virus could actually infect and spread through a tumor. So to that end, we reasoned that if we injected the tumor in the center and then took a snapshot a couple of days later, we would actually see three zones of viral replication. We would see a central zone of necrosis, and that would be then surrounded by a zone where the virus had spread out to and was infecting the cells actively. This second zone, therefore, we would see viral particles or staining with the virus. And then there would be a zone where the virus hadn't gotten out to yet. So there would be a central zone of necrosis where the virus killed, the zone of active replication, and then the zone of where this virus is heading to. And in fact, in our animals, we were able to show that. Here's a photomicrograph of one of the animals in which you can see the central necrosis, these inclusion bodies inside the virus-stained cells, and then the virus-infected cells, and then the tumor beyond that. And if you stain this with viral proteins, you see the necrosis, and then you see the active virus in this second zone. So based on this, we brought this agent to a phase 1 clinical trial, which we actually completed several years ago and reported the results in the Journal of Clinical Oncology at the end of 2018. So this was a unique trial. We enrolled patients with recurrent malignant glioma, essentially glioblastoma. It was a phase 1 trial, so it was a dose escalation trial. We actually had 2 arms in this trial. In the first arm, we did a stereotactic biopsy and injected the virus into the tumor, and then essentially simply followed the patient for toxicity and response. So that's sort of the standard way you would do this kind of a trial. However, we also had this second, more unique arm, which was a biological endpoint arm, or what now people call a window of opportunity arm. in which we injected the virus into the tumor. And we did that through an implantable catheter. We left that catheter in place. We cut that catheter, closed the patient up. We then waited 14 days and then did an en bloc resection of the tumor along with the catheter, not disturbing the catheter, so we knew exactly where we injected the virus. And that gave us a biological specimen to examine the ability of the virus to replicate in a human tumor. Then after we took out the tumor, we injected the wall with virus and then closed the patient up and followed them for toxicity. And as I said, this was a dose escalation trial. So we escalated the dose in 8 cohorts from 1 × 10⁷ viral particles to 3 × 10⁻⁻. And we were able to show in both of these arms that this was a very safe virus all the way up to our highest dose of 3 × 10⁻⁻. And that became our phase 2 essentially dose. The most important part of the trial, I thought, was this biological arm in which we were able to prove that this virus could replicate in a human tumor, really showing this for the first time. So here's an example of one of those en bloc resections. You see the catheter here sticking out of the tumor. This section was fixed in formalin. We then cut the section, the resection tumor perpendicular to the catheter. And you can see the catheter here throughout the tumor. And then we cut sections and then stained it for the virus. And you can see here that we actually saw large amounts of viral proteins within the tumor. And most importantly, we were able to recapitulate the 3 zones that we had seen in our animals. We were able to recapitulate those in these human specimens. You see here the central zone of necrosis, the second zone of active viral replication around that, and then the zone of yet to be infected cells. And importantly, this biological effect actually translated into some clinical efficacy. In fact, 3 of our patients had a complete response in which the entire tumor disappeared. And this response was quite durable. In all 3 of those patients, it lasted for over 3.5 years. And then we had a larger number of patients that had stable disease, and about 20% of our patients actually lived long-term up to almost up to 5 years after the injection. Here's an example of one of those cases, just to show that these weren't small tumors. This was a patient with a left parietal occipital tumor, underwent injection of the virus, stereotactic biopsy, proving that this was a recurrent glioblastoma. And you can see here, this is 3.5 years later, a complete regression of that tumor. Actually, the ventricle you don't see here has now expanded because the tumor has resolved. So an interesting result. Now, several lines of evidence suggested to us that in addition to the direct oncolytic effect, there was also an indirect, potentially immune response. The first line of evidence was the pattern of enhancement we saw after the injection. In fact, in all 3 patients where we had a complete response, in the first 3 to 4 months after the injection, we actually saw increased enhancement around in the tumor. And in many of these cases, we actually thought we should operate because it looked like the tumor was getting worse. But because the patients were doing well, we actually continued to follow them. And then the tumor started to regress. So this pattern has now been considered to be pseudo-progression and is often considered to be an indication of an immune reaction. In fact, we were able to document that in several cases. Here's an example of a case in which we injected into this temporal tumor. We injected the virus in the front here of a part of the tumor. And then only about a month and a half later, we started to see necrosis, but the tumor was starting to look worse. The patient was actually having symptoms. There was more edema. And so we went in and took that tumor out. Here you can see the post-op scan. But interestingly, when we examined that specimen, essentially all we saw in that specimen was a large amount of immune cells, and there was essentially no or very limited number of tumor cells. These immune cells were primarily T cells, and most importantly, we saw large amounts of cytotoxic CD8 T cells, as exemplified here by the brown staining within this tumor. So based on that, indicated to us that during this period of worsening, there was actually probably an inflammatory process going on. And so we went back and re-examined our pre and post-treatment specimens from our arm B, and we were able to show that there was a statistically significant increase in T cells within the tumor, and also a trend toward an increase in cytotoxic CD8 T cells. So based on that, this has now given us the idea that this virus actually acts by 2 mechanisms. The first is, as I initially said, it acts by direct oncolysis, in which the virus gets into the tumor, replicates, and kills the tumor cell. But it also acts by a second immune-mediated mechanism. Essentially, this is a form of immunotherapy. What we think happens is that the virus gets into the cell. In the process of killing the cell, it releases the so-called pathogen-associated molecular patterns and danger patterns. And this then activates the innate immune system, calling into the tumor macrophages and antigen-presenting cells. Then as the virus is killing the tumor, it also releases or starts to present tumor antigens. These antigens are picked up by the macrophages. They're presented to the T cells, and you induce essentially an anti-glioma immune response. Now remember, it is a virus, so we are also inducing an anti-glioma an antiviral response. And so what we think is that there's essentially a battle between the immune system knocking out the effects of the virus and the immune system being activated against the tumor. And if that can happen, if that switch from the fighting the virus to fighting the tumor can occur, we can actually get a very dramatic anti-glioma response. And so that's really the essence of what we think is happening now with this agent. So the question became, is it possible, or can we prove that you can actually induce an anti-glioma immune response? So to do that, we went back to the laboratory. One of the problems up to this point was that we had only been studying this virus in immune incompetent mice. And the reason that is adenoviruses are actually selective or permissive for humans. They don't replicate very well in mouse tumors. So in order to study this, we needed to use a mouse tumor in a mouse immune competent system. But the mouse tumors aren't killed very easily by adenovirus. And in fact, however, there is a mouse glioma model, GL261, which has some ability which the virus is able to replicate in somewhat, not well. It's about 200-fold less effective. And you can see that here because if you implant that tumor, GL261, into nude mice and inject the virus, nude mice have no immune system, you just get a very slight increase in kill. However, when we put that tumor into the immune competent black 6 mice and treat them with the virus, then suddenly we were able to see a 40% increase in survival of the mice, indicating to us that actually there must be an immune response. And indeed, if we looked at these tumors, we could see large increases in cytotoxic CD8 T cells within the tumor. But then the question became, can we actually show an anti-glioma response? And so to do that, we isolated T cells from the spleens of these mice, and then we cross-cultured the T cells from the splenic T cells with the GL261. And only in the mice where we got the T cells from those treated with the virus could we see an activation of the T cells when they were cultured with the GL261, as indicated by interferon gamma secretion. So the upshot of that is that, in fact, we were able to show in these studies that we were able to induce an anti-glioma immune response by treating animals in an immune competent system. So we really believe that these two mechanisms of action, this oncolytic effect and this immune-mediated effect, are the way this virus works. And if, in fact, maybe the predominant way this virus works is by activating the immune system. So based on that, we now have hypothesized that we can increase the efficacy of this oncolytic virus by actually enhancing the anti-glioma immune response. So in that context, we thought that one way we would be able to attack or increase the efficacy would be to combine our oncolytic virus, Delta 24, with immune activating agents, in particular the so-called checkpoint inhibitors. So as I think many of you know, there's been a big boom in cancer therapy with the development of immune checkpoint inhibitors. So there's several immune checkpoints. One of these, the first one that was found was CTLA4, and the other more recent one was PD-1, which binds to the PD-L1 ligand. And basically, these checkpoints turn off the immune system, and they've been shown to be very highly overexpressed in tumors. And so several agents or therapeutics have been developed against these. You're probably familiar with ipilimumab, which is the anti-CTLA-4. And then there's another one, pembrolizumab, and several others, which block the anti-PD-1. So we thought maybe we could combine our Delta 24 with one of these, and through a relationship with Merck, we selected to combine it with pembrolizumab. Now, the rationale for combining Delta 24 with this checkpoint inhibitor pembrolizumab is based on both the drug pembrolizumab and the Delta 24. So as many of you probably know, pembrolizumab and these checkpoint inhibitors have been most effective against tumors like melanoma. And it turns out that melanoma is what's been considered to be an immunogenically hot tumor. In other words, at the baseline, there's a large number of immune cells in there. And so by giving pembrolizumab, you basically free those immune cells up from their inhibition, and now they can go and attack the tumor. It turns out, however, that glioblastoma, as I said, is very immunosuppressed, so there's actually almost no immune cells within a glioblastoma. And so it's considered a cold tumor. By giving Delta 24, however, we call in the immune system. We're essentially turning this cold tumor into a hot tumor, and therefore, when we combine it with pembrolizumab, this now hot tumor can be freed up, and these immune cells can attack the tumor. From the point of view of the virus, it turns out that when a virus infects a tumor cell, it actually results in the expression of these checkpoint inhibitors. So the virus doesn't want to be attacked by the immune system, so it essentially tries to turn the immune system off. So it expressed PD-L1 on its surface. So we thought that if we would block this upregulation of the immune checkpoint inhibitor, we would be, by adding pembrolizumab, we'd be able to overcome that in terms of the virus. So for both of these reasons, we put together a phase 1/2 clinical trial combining Delta 24 with pembrolizumab. This was led by the company DNatrix and by our relationship with Merck, who provided us with pembrolizumab. This was actually a multi-center trial, and multiple institutions, about 12 institutions across the United States participated. There was initial dose escalation as we elevated the DNX virus. We went down and then went up. And then we went into a larger phase 2 expansion. In this trial, patients underwent a biopsy for recurrent malignant glioma on first or second recurrence. And then they had an injection of the Delta 24 at 3 × 10⁻⁻ viral particles, which we found in our phase 1 trial. And then every 3 weeks, they were treated with IV pembrolizumab. We actually entered 49 patients in the trial. We dose escalated without a problem. And then once we were at the highest dose, we entered 42 patients. All of the patients received the Delta 24 injection. And then they received the pembrolizumab, usually around 7 cycles of the pembrolizumab. So the treatment was well tolerated. Shown here is the waterfall plot. We actually had 2 patients who had a complete response and 2 had a partial response for an objective response rate of almost 10%. And about 50% of the patients had clinical benefit with at least stable disease. Shown here is an example of a particularly dramatic response. This patient had this tumor in their motor strip region. They were actually hemiplegic. They were treated with the virus, went through a little bit of a rocky period, and then, as you can see, the tumor essentially completely disappeared over a period of 61 weeks. And this patient actually is still alive and is one of the long-term survivors. Here you can see the swimmer's plot. This was updated several months ago, and it's not the final data, but you can see that there were a large number of patients who are still alive over 12 months. And the median survival after injection with the pembrolizumab is over 1 year from the time of treatment. And indeed, the patients that had these complete and partial responses, all of them are still alive long term. So the net result of this is that we're actually moving this to a phase 3 trial of combining Delta 24 with pembrolizumab, and hopefully that trial will be getting underway in the near future. So while that was moving forward, this combination with the stem cell, the checkpoint inhibitors, we also know that in addition to these checkpoint inhibitors, there are also checkpoint activating agents. These include things such as GITRL, 411B, and another very potent one is called OX40. And so as these checkpoint inhibitors turn off the immune system, these checkpoint activators actually are important in turning on the immune system. So we thought that that another way of enhancing the immune response of our oncolytic virus would be to insert the ligands for these checkpoint inhibitors into our oncolytic virus. And we chose as our first attempt OX40 because OX40 has very important immune activating features. It can upregulate the innate immune system by increasing NK cell activity. It can turn on the cytotoxic TD8 effector cells, and it can also actually turn off these so-called Tregs, which are the inhibitory immune cells in the tumor. So based on that, we thought that we would generate what we call the next generation virus by inserting the OX40 ligand into the Delta 24 background. And we called this virus Delta 24 RG-DOX, or DNX2440, and this was developed again by Dr. Foyo. And we went now to see if this virus could activate the immune system. So we again implanted our GL261 into the tumor. We treated the tumor cells, and then we took the tumors out, and we were able to show that this virus resulted in a dramatic and significant increase in cytotoxic, in T cells, particularly the cytotoxic CD8 T cells, which was 5 or 6-fold more than the Delta 24 itself. Equally important, we took TILs out of the tumor, or the tumor infiltrating lymphocytes, and we were able to show that this virus was able to activate an anti-glioma response much more effectively than the Delta 24. So at the molecular level, it was really doing what we thought it was, we had developed it to do. Most impressively, in our animal studies, we implanted GL261 in the mice. We treated them with the virus, this Delta 24 RG-DOX. And importantly, we used a dose of RG-DOX that when we used that same dose for Delta 24, we really had no effect of the baseline Delta 24 virus. But at that very low dose, this RG-DOX virus was able to cure essentially 80% of the mice. More importantly, when we then re-challenged those mice that had been cured by putting a new tumor in the opposite side of the brain, 75% of those mice did not form tumors and lived long term, indicating that we actually had induced a memory response against the tumor. And if we put in a different type of tumor, here we used the melanoma, there was no effect, indicating that this anti-glioma response was specific to the glioma that we had put in. So we had induced both a memory and a long-term specific response. So now we have this pipeline of other immune-stimulating oncolytic viruses. Not only do we have the OX40 ligand, but we also inserted now the GITRL ligand and the 411B, 411BB ligand. And we now are testing each of these to see if they are effective in different tumor types, or in combination, we can have a more robust response. So that's the idea of enhancing the immune effect to enhance the effect of the virus. Either the strategy of combining it with checkpoint inhibitors, or creating these next generation viruses that themselves activate the immune system. And we're now hoping to move these second generation viruses into phase 1 clinical trial. So I've been talking so far about the virus itself. Another important aspect that we learned when we were studying this virus in our phase 1 trial was that the way we were delivering the virus might not be optimal. And indeed, when we looked at our post-treatment specimens from that RMB, we had 11 of those specimens, and it turned out 5 of them we were actually not able to find the virus. And we thought that there's probably multiple reasons for that. But one very obvious reason was that when we injected these the virus into these tumors, a lot of the virus actually comes up and backflows up the catheter. And anyone who's done these kind of injections knows that that's a big problem. And even if the virus gets into the tumor, it's still hard for the virus to spread widely throughout a large glioblastoma. There's a lot of obstacles to that. There's areas of necrosis, there's areas of hemorrhage, the edema, et cetera, might prevent that spread. So as we thought about this problem, we realized that we really wanted to deliver this virus intravascularly. The idea here was that if we could deliver the virus intravascularly, it could get into large parts of the tumor simultaneously, set up sort of foci, and then these foci, the virus would start to replicate, and then that could coalesce and really probably be much more effective in killing a large tumor. Unfortunately, intravascular delivery of adenovirus is really prohibitive. They go to the liver, they cause liver damage, and they also cause a massive immune reaction, which would result in peripheral organ toxicity. So to overcome this, we turned to another biological therapy, and that is stem cells. And we thought that maybe we could sort of load the virus into some of these sort of stem cells and deliver the virus through stem cells. There's different types of stem cells we could use. There's neural stem cells, there's hematopoietic stem cells, but our group was amongst the first to turn to the bone marrow and to particularly use this type of stem cells called mesenchymal stem cells. These mesenchymal stem cells, as I said, arise from the adult bone marrow. They are thought to give rise to the marrow stroma and to provide the microenvironment necessary for marrow homeostasis. They have a lot of advantages. They actually are easily acquired. They grow in the spindle shape on plastic. The isolation and expansion techniques, when we started this, were well defined. We also realized that the patient could act as their own donor, as you can acquire these from a patient. And there's no ethical issues around their use because they come from adults, and they've actually been tested in clinical trials for other reasons. So the rationale for using these stem cells is based on the idea that these mesenchymal stem cells, although they reside in the bone marrow, they actually circulate. And these circulating stem cells are thought under physiological conditions to be drawn out of the circulation and into tissues in times of injury, with the idea that these mesenchymal stem cells potentially help repair these injured tissues. So because tumors secrete a lot of growth factors and are essentially somewhat of a non-healing wound or an injured tissue, we hypothesized that these mesenchymal stem cells would actually be able to home into a brain tumor and therefore would be able to deliver our oncolytic virus. So to test this, to test whether they could home into a brain tumor, we implanted tumors into brains of mice. We then obtained our mesenchymal stem cells. We labeled them in our initial studies. We labeled these mesenchymal stem cells with this red fluorescent dye eye. We then injected the cells into the carotid artery of the animal. And then several days later, we took out the tumor and examined the tumor to see if we could get the stem cells, if we found the stem cells inside the tumor. And indeed, in a paper we published now way back in 2005, we were able to show that these mesenchymal stem cells can home into the tumor. Here you see a typical example of an unstained section with the tumor here, the H&E showing the tumor here. And when you look under the fluorescent microscope, we could see large amounts of these red labeled fluorescent stem cells within the tumor and not within the rest of the brain, indicating that these stem cells had a specificity and were able to home to the tumor. And this didn't matter if we injected the carotid artery on the ipsilateral tumor or the side of the tumor or the opposite carotid artery. We could get nice uptake into the tumor. And then we proved that this homing actually occurred in our glioma stem cell lines. You can see here 3 different glioma stem cells with different patterns. And in all of these cases, we were able to see large amounts of mesenchymal stem cells, this time labeled green, inside of the tumor. So it appears that these mesenchymal stem cells have an intrinsic ability to home to the tumor. So based on that, we now wanted to know, would these stem cells actually be able to home to the tumor if we loaded our oncolytic virus into the tumor? And so to test that, we again implanted the tumors in the brain. we grew our mesenchymal stem cells. This time we labeled them with green fluorescent protein. We then loaded them with the Delta 24 virus, injected them into the carotid artery, took out the brains. And then again, here you can see that we saw even these Delta 24 loaded mesenchymal stem cells home nicely into the tumor, as seen by all of these green mesenchymal stem cells inside the tumor, but not inside the opposite brain. So the loading of the Delta 24 didn't interrupt the homing capacity. We next wanted to see, could the virus actually get out of the stem cells and infect the tumor? So to do that, we again used our same protocol. We injected these green labeled mesenchymal stem cells loaded with the virus into the carotid artery. And now we took out the brains and we stained them both for the green fluorescent protein, and we also stained using a red fluorescent marker for the viral protein. And basically what we reasoned and hypothesized was that at first, the green labeled mesenchymal stem cells would get into the tumor. And so when we took out the tumors at day 4, we saw large amounts of green cells within the tumor. And then as the virus replicated in the mesenchymal stem cells, and then we stained for the red virus, or stained with the red fluorescent protein for the virus, we would see red fluorescence inside the green cells, and red and green make yellow on fluorescence. So we would see yellow cells a little bit time later. And indeed, day 7, when we took out our tumors, we could see these yellow cells within the tumor. You see here a nice nuclear yellow, and you would expect this virus to be replicating in the nucleus. So that was a nice indication that the virus is replicating in the cell. And then these mesenchymal stem cells would actually be lysed by the tumor, by the virus. The virus would then be released, and then we would see red stained fluorescence in the tumor cells. And indeed, on day 11, we saw a large amount of red cells. So essentially, when you graph that or quantify that, we could see the green cells arriving and then disappearing as the virus is released, and then the red fluorescent increasing as the virus infected the cells. So we had shown in these preclinical experiments that the virus can actually get out of these mesenchymal stem cells, infect the tumor cells. And in fact, that effect, that biological effect, translated into efficacy. And as you can see here, in 2 independent experiments, we were able to show that this delivery with these mesenchymal stem cells resulted in cures of these animals in 30 to 40% of the cases. So based on that, we've actually brought this approach to a phase 1 clinical trial. We're using allogeneic bone marrow stem cells. We originally were thinking of using autologous, where we would acquire them from the patient. But because it takes several months to grow these mesenchymal stem cells, we decided to use allogeneic, basically off-the-shelf bone marrow cells from a donor. And we load them with the oncolytic virus, and then we administer them via intra-arterial injection into patients with recurrent gliomas. To do this trial, we've actually partnered with Elizabeth Spall, the head of our stem cell transplant group here, and they've actually been growing these mesenchymal stem cells for many years to use for other purposes in cancer therapy. So we had all of that in place to do this clinical trial. Equally important, we partnered with Peter Kahn, who's an endovascular neurosurgeon, was at Baylor College of Medicine and has now become the chair at UTMB. And we worked very closely with Peter developing this approach. In fact, we think that this intra-arterial approach can be used not only for delivery of mesenchymal stem cells, but it potentially can be used as a way to deliver a large number of agents or a variety of agents to brain tumors. And we've coined this phrase ESIA, or this acronym ESIA, for endovascular selective intra-arterial infusion of mesenchymal stem cells. And we think this approach is something that further needs to be explored for the delivery of these kind of agents. So as part of our preclinical testing, we wanted to show that all the microcatheters, the commercially available microcatheters, could be used and were compatible with our virus and our mesenchymal stem cells. And indeed, in a series of preclinical studies, which we've now should be coming out in the Journal of Neurosurgery, we were able to show that these our mesenchymal stem cells are compatible in all ways with the various commercially available stem cells. The stem cells don't stick to the catheters, and these catheters, the small size, doesn't shear the mesenchymal stem cells. And equally important, we wanted to prove that when we inject these cells into an animal, that we wouldn't be causing strokes. That was our biggest concern, that injecting cells would result in microthrombi, and these cells would clump and then cause strokes in our patients. And in a series of 10 animals, we basically recapitulated the entire process where we grew up our mesenchymal stem cells, loaded them with the virus, then did a transfemoral access to a series of dogs, and injected these dogs either into the internal carotid or the posterior circulation, and then analyzed the animals. And we were able to show that we didn't induce any strokes in our animals. We had controls as well. And we could inject up to 1 × 10⁸ cells in 10 mLs, or 1 × 10⁷ cells per ml as our highest dose without causing any trouble. So based on all of that preclinical work, we actually put together this phase 1 trial. The trial actually, again, has 2 arms. In the first arm, which is a dose escalation trial in recurrent glioblastoma, we're doing intra-arterial ESIA injections into the carotid artery, or into the selective middle cerebral artery or posterior cerebral circulation. And then we're essentially just following the patients in the typical arm A. And once we get to the highest dose, we're then going to enroll patients into arm B, in which we again will do the injection and then do an en bloc resection, looking at the post-treatment specimen with this biological analysis. And our hope is that now, whereas in the past we saw just a localized virus, we would now see virus throughout the whole tumor. So in fact, here's our dose escalation. We're escalating up to that highest dose of 1 × 10⁷. And then we added an extra arm where we would do 2 injections rather than 1. We've actually started this trial in April of 2019. We've enrolled 9 patients, getting up to cohort 3. Our third person actually just had seizures after the injection, so we're actually going to enter 3 more patients in cohort 3. But you can see that all of these patients had glioblastoma. They were of mixed sex. They were all relatively on the older side. The majority were unmethylated tumors and had EGFR amplification. And they've had multiple prior treatments. In many cases, this patient actually had 6 prior therapies. I know this slide is busy, but the bottom line here is that we started out doing transfemoral approach. We've now moved to injecting or accessing the system through the radial artery. The tumors were located in all different parts of the brain: occipital lobe, temporal lobe, frontal lobe. And then we've done injections into the posterior cerebral artery, as well as into the A2s or the middle cerebral artery branches. Most importantly, we've seen on our post-injection angiograms no arterial occlusions. Our post-MRI DWI, we've seen no strokes up to this cohort 3 level. And all of our patients have been neurologically intact after the injection. Here's just a couple of examples. Here you see this posterior, this occipital tumor, which we accessed through the posterior cerebral artery. And in fact, all 3 of our first patients, we needed to go through the vertebral artery. We were actually hoping to not do this initially, but this is how it worked out. And we're now pretty confident that we can inject these cells through any part of the brain. And here you see the evidence that there was no strokes after these injections. This is our outcome to date. Some of the people in the early cohorts have actually died, but many of the people in the in these later cohorts are still alive and doing well. We had one interesting case so far one of our longest term survivors, shows an interesting pattern. Here's the case. This is the patient was treated in August of 2019. She had a large tumor in the posterior temporal occipital region here. We actually, about 2 months after the treatment, and shown here on the MRI, this patient developed all of this necrosis. And if you looked on the flare, there's a large amount of flare that's actually extending across to the opposite side of the brain. We actually thought this therapy wasn't working very well. The patient was having symptoms. We wanted to start her on steroids because of the more edema. And so we decided to take that tumor out. Here's the post. We took the tumor out. And then here's the scan now in August of 2020, so about 12 months later. And you can see that there's no enhancement around that, and all of the edema, all of the flare has completely gone away, even the stuff that looked like it was crossing to the other side. So we think that what potentially, the optimistic view here is that we induced an immune reaction, and then by taking out the mass, the necrotic mass, we were able to allow then the immune system to clean up the rest of the tumor, and this patient is now doing well this far out after the resection. So there's this idea that this mass, with the induction of all the inflammation inside this closed space of the brain, is actually problematic, and by taking that out, you can allow the immune system to go to work. So one of the interesting parts of this trial is that we've been also performing a co-clinical trial. And by that, I mean that we inject the cells into the patient. We're actually prepared 30 cc's, 30 mLs of cells, and we're injecting 20 mLs into the patient, which leaves a 10 ml residual. So rather than throw that away, we actually bring that back to the lab, and Joy Guman and Dan Ledbetter in the lab take these cells, and then we've been examining them to see what's the effect of these cells that we're giving to our patients. Are they effective in the laboratory? So we first tested to see if the dose that we were planning to give was the actual dose of the cells. And you can see here that by simple counting, in fact, with each cohort, we were delivering the appropriate number of cells. Equally important, we stained all of these cells for the virus. And you can see here in all of the cases, we did one of the cases in COVID, and we were unable to get the specimen during the COVID period. And equally, two of these other we did through COVID, but we were able to get them because we did them more recently. But you can see here positive staining in the cells, and we typically can show that there's about 75 to 80% of the cells are infected. Some of them are a little lower. These two had 64 and 69%. But there's clearly virus being loaded inside these mesenchymal stem cells. Equally important, in vitro assay, we take these cells back to the lab, we layer them on the top of a transwell dish, and then we put in the bottom of that dish U87 glioma cells. And as you can see here, in every one of these cases, the cells from the patient were able to release the virus and then kill the U87 cells, as shown here by the low cell counts after treatment with the virus and mesenchymal stem cells in all cases. One of the most interesting things we did was we took these cells back and we had prepared mice with U87 gliomas in the brain. And then we injected these mesenchymal stem cells that we had previously, the other part of the specimen we had given to the patient, we injected these residual cells into the mice. Now, important here is to realize that in the patients, we were giving 20 mLs, and obviously you can't give that large volume to our mice, so we could only give 100 microliters to the mice. And so here you see our cohort 1 group. In the patients, we delivered 2 times 10 to the 6 and 20 mLs, which is 10 to the 5th cells per ml. And when we deliver 100 microliters of that to our animals, we're actually only delivering 10 to the 4th cells. So we're delivering a lot less number of cells. And in our mice, both for this cohort 1, we actually take the brains out, stain the specimen for the virus, and we didn't see any virus inside the mouse tumor, raising some concerns that maybe these cells couldn't home to the tumor. However, we also realized that since we were injecting only 100 microliters, when we usually do these experiments, like I showed you in the beginning, we typically inject 10 to the 7 cells per ml. So that would give us, if we inject 100 microliters of that, that would give us 10 to the 6 cells. So what we did was we took our specimen, we spun it down, and we reconstituted it at 10 to the 7 cells per ml, injected 100 microliters of that into our mice. And when we did that, in essentially delivering this higher concentration, we saw large numbers of mesenchymal stem cells in the tumor. So this suggested to us that at this lower concentration, which is our cohort 1, we might not be actually getting a lot of virus in the tumor. But if we increased our concentration, and in other words, as we dose escalate, hopefully we'll get the cells into the tumor. And so a similar thing happened at cohort 2. When we inject 100 microliters of the dose that was given to the people, in one of either the 3 animals, we saw a virus. But then when we spun it down and reconstituted it at the higher cell level, we actually see virus in the tumor. So in this clinical trial, it's really suggesting that these cells can home to the tumor, but we have to continue our dose escalation to get it up to probably a concentration around 1 × 10⁷ cells per ml. So we're continuing that, and hopefully as we dose escalate up, we'll be able to do our RMB and prove that at these higher doses, we'll be able to get the virus into the tumor. So in conclusion, I think that these biological therapies represent a novel class of agents for treating gliomas. I've shown you the Delta 24, that it can work by both direct oncolysis and immune activation. And then I've shown you 2 strategies for enhancing the immune effect. One is combining Delta 24 with pembrolizumab, and we're about to go on and test that in a phase 3 trial, hopefully. And then the second is to actually use these next generation viruses where we've inserted these virus stimulating molecules. And one of them is RG-DOX, and we have this whole pipeline, which we're hopefully testing soon in clinical trial. And then lastly, hopefully I've convinced you that mesenchymal stem cells may be an effective way to deliver these viruses. And we are currently in our phase 1 dose escalation trial, where hopefully as we get up to higher doses and the correct concentration, we'll be able to prove that we can use these mesenchymal stem cells to deliver the virus. And I think in some, I hope I've convinced you that these agents, these biological agents, are really powerful because they possess these intrinsic properties that allow them to overcome many of the problems of treating cancer and can be potentially effective in glioblastoma. So I just want to thank all the people who have worked on this. Many people have come to my lab to work. I've had good collaboration with my colleagues and the other neurosurgeons in the department helping with the clinical trials. Neuro-oncology, particularly Juan Foyo, who developed the virus, has been a great collaborator. And then Peter Can and Elizabeth Spall currently helping with our MSc trial. And of course, all of our donors and funding mechanisms. So thank you very much. I appreciate your attention.
Hey, Fred, that was a great talk. Thanks so much. Quick question. I was wondering what the role of your fellows are with your research. I mean, you guys get 3 to 4 fellows a year, obviously top notch. How do you integrate them into your translational and basic science?
Yeah, that's a great question. So our fellowship is a 1-year clinical fellowship, really. So the fellows, we actually have a clinical trial course, which we've recently started. So during their fellowship year now, they're expected to write a clinical trial. They participate in the clinical trials in the sense that now we're doing our MSc trial. So they help with the surgery, which now actually is an endovascular treatment. And then, so through that, they actually learn about what we're doing and get some experience in carrying out clinical trials. Over the years, several of the fellows, and it's essentially at their discretion, have decided to work in the laboratory. And some of the fellows do an extra year. So there is the option to do a 2-year fellowship with 1 year of research. And we've had fellows do that over the years, working either with myself, Dr. Heimberger, Dr. Rao, and in that way they get involved in the either part of the preclinical or assessing the specimens. So right now, actually, I have a fellow, one of our fellows, Chiba Ene, is actually in the lab and is starting to help with the staining and analysis of the post-treatment specimens that we're acquiring. So that a lot of it depends upon, in terms of the actual research, the interest of the fellow and whether they want to do an extra year or participate in the laboratory during their 1 year. participating in the laboratory during the 1 year can be a little bit challenging because of the clinical responsibilities. But over the years, several of the fellows have done that.
Got you. And the other question is, I mean, you guys have amazing clinical trials. How do you get the word out? How do you market? How do you make sure that the patients and that the referring doctors know about the cutting edge work that you're doing? Because it's great to have the data, but if no one knows about it, then they're not going to be enrolled. How do you guys promote what you're doing?
Yeah, that's a great question. So when in many ways, so all of our trials are advertised on the NCI.gov, you know, the clinicaltrials.gov site. So we get a lot of people coming through that. As you know, MD Anderson is a tertiary cancer center. We're constantly getting referrals, obviously, particularly recurrence, with people actually looking for clinical trials. So our population of patients is often those who are searching for clinical trials. Harder is inside our institution, inside our group, we have so many clinical trials that there's a little bit of a competition, right? We have to prioritize the ones that we want to do, and that's where we have more of a challenge. So deciding whether a patient goes on one trial or another trial is really the challenge. We have plenty of people coming who learn about the trials through our websites, through the NCI.gov. Sometimes we're on some social media when a person participates in trials. Many of the patients actually go on social media to say they're in the trials. But advertising hasn't been a major problem. The bigger problem is prioritizing inside our group. And when we have a patient who's, a second recurrence, we have lots of options for that patient. And then which one they choose is often a rate limiting step for joining people in our trials. So I think that's a long answer to that question.
No, it makes sense. It's great to hear that.
Fred, Mike Ivan here. This is fantastic talk and really inspiring work that you guys are doing. Two questions. One was with Pembro. I was wondering if it matters the timing of how much immune activation each patient needs, and is that consistent with each patient as to know when to then give Pembro after the actual virus is given?
Yeah, that is a great question. So there's so many unanswered questions just like that need to really be addressed more carefully. In fact, full disclosure, there's sort of an internal battle, whether, I don't know if battle is the word, but discussion about whether we should be moving to a phase 3 trial so quickly, because there are a lot of questions like that unanswered. And so it's not entirely clear. The timing could matter, right? You don't want to unleash, and the issue I think is that the virus, we're doing it's a competition between the immune system attacking the virus and turning off the whole system, and the immune system seeing tumor-associated antigens or neoantigens that the virus has to sort of expose through the process of replication and kill, right? And the time course of all of that is not really clear. So if you look at the history of oncolytic viruses, 10 years ago, everyone was saying that, oh, we got to turn the immune system off. We got to turn the immune system off. The virus is going to be shut down by the immune system. And that is probably true. The virus is shut down by the immune system. So we're not sure why some people, there's this sort of switch to an anti-glioma response from an antiviral response. We don't really know the mechanism of that. And we don't know, should we, for example, be giving steroids for a period of time to hold the immune system in check while the virus replicates and then release the immune system? Should we, what exactly is the timing? We're doing 10 days after the viral injection. That's when we give our first Pembro. Does that make sense? Should we be doing longer? Should we be doing shorter? I'll tell you that right now, that's sort of an empiric strategy that we're using, and a little bit based on sort of the logistics of you know, when we think it's easiest to get the patient back and things like that, when the wound's healed, stuff like that. We actually are trying to study this better. As I said in the beginning, the mouse model is not a great model because the virus doesn't replicate very well. And the GL261, which is the best system, is already immune activated. So it's not a very hard model to kill. So we've actually recently developed a hamster model. It turns out that there are only two other animals that the virus is permissive in. One is cotton rats, which are very aggressive, and the other is Syrian hamsters, or golden hamsters. So the problem with the golden hamster was that there was no brain tumor model that you could implant into a hamster. So we took neural stem cells from the brains of our mice. We transfected them with 3 genes, and we were able to induce a tumor, basically glioma stem cells that are hamster-based. And now we have glioma tumor cells that we can implant into the hamster. And we have a completely syngeneic immune competent system that's relatively permissive to the adenovirus. And we're now starting to study that. And in an initial study we did where we treated the animals with decadron for a long period of time, we attenuated the effect of the Delta 24. So now we're trying to shorten that time and see if there's an optimal window that we can enhance the effect of the Delta 24. So there's a lot of questions that still need to be answered to optimize this therapy and make it most effective. My fear is that we jump too quickly into trying to do a phase 3 trial and you haven't worked all this out, then that trial doesn't work, quote, work, because it's only a subpopulation of people who you see a response, and then the whole field gets stopped because of that trial. So we'll see how this evolves over time.
Yeah, no, I mean, those are those questions that I have. I mean, we're looking much more simply just at, you know, our lit patients and just trying to predict who has an immune response to lit and who doesn't. And we've seen that it's quite a variable response. I mean, just looking at the neutrophil lymphocyte ratios and other aspects of the, you know, the flare signal afterward, and it's all over the place. Very hard to predict who kind of, you know, how they respond in their immune system. So with the virus, I can imagine it's also going to be quite different patient to patient. The other question I had was, do you think it matters if you do the viral injection either when there's a large mass of tumor or after resection? And does that amount of initial tumor that gets infected and creates that immune response matter?
That's another great question. So we actually came to the conclusion through a variety of experiments and even our clinical trial that it's actually better to have a tumor mass there. Taking the tumor out and then injecting the wall is probably less effective because the residual infiltrating tumor cells, there just might not be enough of them to induce an immune reaction. So we actually think that probably the better strategy is to treat the enhancing mass, right, and allow the immune system and allow the replication in that mass. There's probably much more probability of releasing tumor antigens, et cetera, and activating the immune system than with a more scattered, diffuse kind of tumor. And then we think that once that immune reaction happens, because the brain now is responding, there's probably a very immunosuppressive response. So if you can then get that mass out, you can then unleash the immune system on all the infiltrating tumor cells. And that was one of the cases I think that I was trying to show that might be a strategy going forward. But there's a lot of speculation in what I just said. But that might be consistent. I don't know if you remember, or recently there was a study by UCLA and Tim Clousie where they did neoadjuvant immunotherapy, and then they took the tumor out, and the patient seemed to do better. And it could be part of that. You sort of need the mass in there for the immune system, in order to expose the antigens. And you need to have a certain critical sort of threshold of antigens for the immune system to be robustly activated. So I think you do need to have some portion of the mass in there to make this work.
Great, thanks so much.
Dr. Lang, sorry, one last question. My name is Ashish. I'm one of the chief residents here, kind of interested in viral oncology. I used to work a little bit in Dr. Kasahara's lab.
Mm-hmm.
And, you know, as you know, into the Togagen phase 3 trial, they didn't really have, they had some responders and a lot of them were non-responders. I'm curious if you guys have kind of looked at kind of the genomic aspect of which patients tend to respond to adenovirus therapy versus those that don't.
Yeah, that's a great question. Our phase 1 trial, the specimens, we were so sort of fixed on figuring out if the virus was replicating and stuff. We really didn't have enough tissue to do complete genomic sequencing and everything on that. That is actually one of the goals, is to do to sequence everyone pre-treatment, and then to get specimens post-treatment. So right now, we do not know from a genetic point of view, what are the genetic characteristics of the tumor that the virus can replicate better in. Clearly, because it depends upon retinoblastoma, you have to have inactivation of retinoblastoma. We think that's pretty common. There's 2 ways to do that. You can have a mutation in retinoblastoma, or you can inactivate upstream genes like P16. And almost all gliomas have loss of P16, and about 30% have the retinoblastoma gene. Now, mutation. We don't know if one of those is better than the other in terms of inducing the replication in the tumor. So I think that's actually an important area of investigation. What is the genetic predictors? I actually think, though, this is a much more complex than just looking at the tumor. As we're learning, as you see from COVID, right? Some people die when they get a COVID infection, and some people act as if nothing happened to them. And so the complexity of your immune system and the individuality of the immune system might predict people's outcome. And that might be as complex as the microbiome of your gut might influence all of that. So the layers of complexity here in terms of what will predict response, I think we're only scratching the surface. And there's lots of research that needs to be done to figure all of that out. There's the genetics, the tumor, the host, and then the microbiome of that host, all are going to influence the response to any of these kind of therapies, which is going to be challenging to figure out. But lots of work needs to be done. And again, that's why I think prematurely jumping into just doing, shotgun phase 3 trials, which is fine if the community can keep the context of that trial sort of in perspective, right? That if the trial fails, there's lots of reasons it can fail, and don't drop the whole field, which unfortunately is what tends to happen, right?
Absolutely. Thank you.
Would that be all for ground rounds today?
Yes, that'll be all, Fred. Thanks so much. I think you're meeting with the residents around 1 o'clock, and
perfect.
That should be great. So again, thanks for joining us. Really appreciate it.
Oh, thank you so much for the invitation. I really appreciate the opportunity, and again, thank you for selecting me for this endowed lectureship. So appreciate it very much.
All right, take care.
Bye bye.